So I'll present my screen after you're done, right?
Yeah, that's right. So are you ready? Should we start?
Yeah, sure, sir.
Okay, just give me 1 minute. I'm just about to start.
Okay, sir.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14I, which is Hematology General and Fundamental. We are streaming live from PGI Chandigarh via Kolkata. And we have a very basic, very essential and very important topic, which is systematic approach to evaluation of bone marrow trephine biopsy, technique and approach. And to talk on that, we have somebody who is extremely talented, very proficient, and very learned. We have Dr. NABHAJIT MALLIK. He's an MBBS from Seth GS Medical College and KEM Hospital, Mumbai. MD Pathology from Ram Manohar Lohia Hospital, New Delhi. With senior residency in the Department of Lab Oncology, AIIMS, New Delhi. DM Hematopathology from PGI Chandigarh. He is right now as an assistant professor in the Department of Hematology, PGI Chandigarh, with interest in flow cytometry in benign and malignant hematological disorders, erythrocytosis, and multiple publications in international and national journals. A person with all the feathers in the cap and very learned and very, very well known in hematology. Before I ask Dr. MALLIK to take over, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. And let me remind everybody, this is session 2. In session 1, Dr. MALLIK had taught us the approach to bone marrow aspiration. So this is a continuation of that. With this, let me request Dr. Mallik, sir, please share your screen and let us start.
Thank you, Dr. Nadeem, for this kind introduction. I'll just try and share my screen right now.
Yes, sir, we can see your screen. Yeah. Please make it full screen, please.
Is this okay now?
Perfectly fine. Please start. Thank you so much.
Thank you, Dr. Nadeem. I thank you for this opportunity. And we start from where we stopped last time. We had done a systematic approach to bone marrow aspirate smears in the previous class. And now we move on to the bone marrow biopsies. Bone marrow examination has both bone marrow aspirate and bone marrow biopsy as the component, and they should usually be done together. But let's see how we approach the biopsies. A lot of things, a lot of concepts that we'll talk about in this class has already been taken in the previous class as well. So I'll skip over those a little quickly and then move on to the main parts. So let's get on to the historical aspects that we discussed in the last class as well. So we know that trephine is a surgical instrument with cylindrical blade used to obtain a cylindrically shaped core of bone. Now, trepanning is a surgical procedure from where this word comes from. In this procedure, a hole is drilled into the skull. It is one of the oldest procedures known to humans, the evidence of medical intervention, and they have been found in various parts of the world. And it was used to relieve headaches, mental illness, and to relieve intracranial pressure. In older times, most probably also to release spirits. Here is a very ancient skull from New Guinea, which shows these trephine holes in the skull. So the crown trephines were used as late as 1700s for therapeutic measures, and they're still being used in burr hole surgery, but not for diagnostic use. And first attempts to obtain a bone marrow sample by surgical trephine for diagnostic reasons were undertaken in around the year 1903 in Italy, and he punctured the top part of the epiphysis of a femur. In 1920s, the bone marrow examination was done from sternum and tibia, and it was only in the 1950s that pelvis was suggested as a source of bone marrow examination. Now, till then, it was not a very popular procedure. It became popular in the 60s, only after Wim Silverman biopsy needle was used by McFarland and Tamshik in the year 1958. And then in the year 1971, Khosrow Jamshidi, an Iranian citizen, he patented his needle, which is now popularly known as the Jamshidi needle. And this design allowed tissue to freely enter the lumen and avoid crushing of the tissue, and there was a significantly lesser pain as well. So after this, there was really a boom in bone marrow examination in hematological practice. Now we quickly go over this. We had taken this in the last class. Why bone marrow examination? Because bone marrow is the major site of hematopoiesis in the body, and there's an important element of it is an important element of the reticular epithelial system. And very importantly, daily average production of the bone marrow per kg body weight is around 2.5 billion red cells, around 1 billion granulocytes, and 2.5 billion platelets. But not just that, it has a huge reserve capacity as well, and it can produce 5 to 10 times the normal capacity if required. That is at the times of stress. Now, quickly, we'll go through that. Bone marrow occupies the cavities of around 85% of the skeletal system. It weighs between 1600 and 3700 grams in a normal adult, and the distribution is age dependent. So, in the neonatal period, virtually the entire bone marrow cavity is fully occupied by proliferating hematopoietic cells. By early adult life, though, the hematopoietic bone marrow, that is the red bone marrow, the bone marrow covered with fat is called as a yellow bone marrow. So, the red bone marrow by early adult life is lying only in the skull, vertebrae, ribs, clavicles, sternum, pelvis, and the proximal half of the femur and the humerus. Here we can see a bone and the medullary cavity which has the bone marrow inside. Right. So, so we move on to the indications for bone marrow examination. So you do bone marrow examination for making a diagnosis and also for disease monitoring. So although marrow aspiration and biopsy techniques are safe, they should be performed with a clear idea. It should not be just done as a part of a routine examination. It should be performed with a clear idea as to how the results will help distinguish the differential diagnosis under consideration or provide follow-up treatment. And in many hematological disorders, such as in most cases of iron deficiency anemia, thalassemias, acquired inherited hemorrhagic anemias, we do not really need a bone marrow examination. So we should keep in mind that all hematological disorders do not have need to be to have a bone marrow examination performed to make a diagnosis. Right. So we come to the various indications of the bone marrow examination, and this is a huge list that is given in the ICSH guidelines for bone marrow examination. But we come to our local experience, which I discussed last time. In 2019 PGI data, we had around 3,200 adult marrows and 770 pediatric marrows. And of these acute leukemias, check marrows is basically the follow-up marrows of acute leukemia to see disease status. So check marrows, NHLs, non-Hodgkin lymphomas, plasma cell dyscrasias, cytopenias, aplastic anemias were the most common indications for bone marrow in our setting. Of these, the first four are the ones that are shown, but this need not be the case everywhere. As we discussed last time, this changes from center to center, and places having hematology or an oncology unit along with it, attached with it, will have high numbers of acute leukemias and NHLs and plasma dyscrasias and such marrows. However, other places which do not have oncology services with them, they might have cytopenias and aplastic anemias and pyroxia of unknown origins as the most common indications for performing of the bone marrow examination. Now let's come to relative advantages of bone marrow aspirate versus bone marrow biopsy. A bone marrow aspirate, as we learned last time, the best cytological details can be elicited from the bone marrow aspirate. And a wide variety of cytochemical stains can also be performed on them. They are very useful for leukemia diagnosis, also for anemias and anemia evaluation, because iron stores can be measured by performing the Pearl stain on these bone marrow aspirates. Again, to see treatment response in acute leukemias, we don't really need a bone marrow biopsy. A bone marrow aspirate is enough. And very importantly, when we have to perform ancillary tests, especially in today's day and age, when we have to perform flow cytometry, cytogenetics, FISH, etc., samples for these come from the bone marrow aspirate. And bone marrow aspirate is much less painful than the bone marrow biopsy, because we are using a much smaller bore needle for this. Now, what are the advantages of bone marrow biopsy then? The biggest advantage is that it gives a very good and by far the better estimate of cellularity of the bone marrow. Also, it gives detailed information of bone marrow architecture and pattern of abnormal cell infiltrate. It is much more helpful in detecting diseases which show patchy infiltration, as in those diseases which do not involve the whole bone marrow together. For example, non-Hodgkin lymphoma, myelomas, or any metastasis coming from outside, or any granulomas. This will not involve the entire bone marrow altogether, but will have focal areas of infiltration. So biopsies will be able to catch them much more, because in bone marrow aspirate, we are just examining one point of the bone marrow, while in bone marrow biopsy, we are looking at a section, a bigger area. It is, of course, very easy to understand why it is helpful in the conditions of dry tap, because in dry tap we don't get any bone marrow aspirate at all. So bone marrow biopsy is what we will be requiring for examination. Certain ancillary tests such as immunohistochemistry can be performed in the bone marrow biopsy. And a very important thing is that it is useful in metabolic bone disorders. The bone character can be studied only in bone marrow biopsy and not in the bone marrow aspirate. With that, we come on to the bone marrow procedure as such. Now, let's go to a bit of a history. In 1930s, Custer described importance of touch imprints for the first time. As we discussed in 1958, McFarland and Dashmuck, they used the Damashek, they used the Wim-Silverman needle, and the modifications further on to it were introduced to have less painful and more biopsy retention rate and get larger core specimens. The first of such modifications was made by Jamshidi, and further modifications were made by Jensen, Swain, and Shack Fisher. So what are the prerequisites for doing a bone marrow procedure? The first and foremost is to have a bone marrow procedure form in which details of the patient for which the bone marrow examination is performed is being filled clearly by whoever is requesting the bone marrow, the clinician that is. So here is the bone marrow examination form that we have, that we use in PGI. We, other than the usual demographic details like name, age, sex, and CR numbers, etc., we also need to know who is the clinician in charge, who is ordering, and we have a space for the clinical data and the proper history of this patient. Other than that, we have asked a lot of questions like was any blood transfusions given, were any hematinics given, What is the build of the patient? Was there any pallor, gum hyperplasia, bony tenderness? Was there any lymphadenopathy? Was there any liver or spleen enlargement? Any abnormalities in the CVS, CNS, lungs, and fundus? So basically, we are asking for all information, all clinical information that is possible for the patient, because we need to examine bone marrows only in the context of proper clinical history. Right. So with that, we move ahead and let's look at what supplies and equipments will be required. So bone marrow examinations are usually performed in the clinic or the bedside, and if it is performed there in the bedside or in the clinic, the equipment must be carried to the site of the procedure. However, sometimes pre-designated rooms are used and supplies must be maintained there, and stocks should be checked regularly. A compartmentalized plastic or wooden tray or wheeled cart with flat surface may be used, and adequate supplies to perform several procedures, not just a few, but several procedures, should be carried or kept stored in that area. Now, there's a table with the number of the various supplies that should be used and that should be kept before doing a bone marrow examination. First and foremost, for obtaining written consent, this is very, very important. No bone marrow procedure, as I said last time, should be done without obtaining a proper written consent from the patient. He should be explained all the factors that are there associated with the bone marrow examination, any risks that can happen. Everything should be explained to him, and a written informed consent should be taken. For the site preparation, we need isopropyl, sterile and non-sterile gloves. We need needle, and we need lignocaine. We need fenestrated drape sheets. For the main procedure, that is the marrow procurement, we need the biopsy needles. We usually use the 11 gauge needles for adults. 8 gauge needles can also be used. They give a broader and much better core, but can be slightly more painful for the patients. And for pediatric patients, a 13 gauge needle is used for the bone marrow biopsy. This is in contrast to a 16 gauge bone marrow aspirate needle for adults and an 18 gauge bone marrow aspirate needle for the pediatric population. Now, we also need sterile containers with 10% non-neutral buffered formalin or whatever other fixative that we are using. We'll discuss that in the coming slides. And of course, need microscopic slides, which are preferably frosted, but even normal slides can do. For the wound care, we need bandage scissors and Dynaplast bandage tape. Now, this is a photograph of the Jamshidi's needle that we are very familiar with. So there are 3 parts. The first is the hollow needle with a beveled tip. There's a beveled tip at the edge. This is the hollow needle, and the obturator is something that goes inside the needle and blocks this hole while we are entering the bone. And once we are doing the procedure, this obturator has to be removed. The obturator and stylet are names that are interchangeably used. This can also be called a stylet sometimes, but this basically goes inside this hollow needle when the bone marrow is being entered. And once it is entered, this is removed, and the stylet that is there, this is used at the end to remove the bone marrow biopsy that has been collected. We'll see this in the upcoming slides. And here is a figure of the beveled edge that we're talking about of the Jamshidi needle, which causes lesser pain and easy retention of the bone marrow biopsy that is collected. Now, we talked about bone marrow biopsy sites in quite a lot of detail in the previous class, so I'm not going into detail for this, but just say that the posterior iliac crest and the anterior iliac crest are the 2 sites, amongst which posterior iliac crest is by far the most commonly accessed site for bone marrow biopsy. A sternum is a big no-no. We know we can do bone marrow aspirates from the sternum, but not biopsies. It will be too risky. Now, what is the bedside preparation that is needed? Microscopic slides should be cleaned and placed on flat surface for touch imprints. Sterile container with formalin to be kept absolutely ready. And now coming to the positioning of the patient. So if you are doing it from the posterior iliac crest, we can position the patient one of 2 ways. You can either position the patient in the right or left lateral decubitus with knees flexed, below under the head and eyes away. Or you can also use the prone position with the head turned away, with the head turned and the eyes away. In my practice, we are doing more bone marrows from the posterior iliac spine with the patient in the prone position, but the left and right lateral decubitus position is also practiced in a lot of places and gives equally good results. When you are doing a bone marrow examination from the anterior iliac crest, you'll of course do a supine position with the hips and the knees flexed and the eyes away. Now, how to prepare the site? For site preparation, you use non-sterile gloves and protective clothing should be worn. Procedure site should be carefully palpated for any anatomical landmarks, and those should be marked, and we should highlight the chosen site. For example, for posterior iliac crest, the upper portion of the upper or central part of the PSIS, that is the posterior superior iliac spine, should be which is easily identified by the dimple in the skin that is there in the back. And for anterior iliac crest, either the center of the prominence of the ASIS or slightly to the or slightly lateral from the center will also do. Now coming to after the site preparation, we come to the skin preparation, and the skin surrounding the site should be cleaned. How should it be cleaned? It should be cleaned using a sterile gauze that is soaked in 10% povidone iodine solution, and the skin should be washed in a circular motion, beginning at the marked point and working outwards. Now after that, we have to remove the povidone iodine from the center of the wash area with a single swipe of sterile isopropyl alcohol. So here in this picture you can see we are starting with the center of the povidone iodine, and we are going outwards. It should not be reversed. Once you started from center, you should only go outwards, and once you've gone outwards, you should not come back in. After you've done this, you should clean it with a sterile alcohol. Now after this is done, we administer the local anesthesia. Now local anesthetic is used to numb the pain and from the skin and periosteum at the site of the barrier procurement. Now 10 ml syringe is usually filled with 1% lignocaine. And we usually use a 22 gauge needle. You can use a smaller gauge needle as well. So first we inject a small amount of local anesthesia intradermally to produce a wheal, a 5 to 6 mm wheal on the in the subcutaneous region. And then after that, we push through the skin and subcutaneous tissue until the surface of the periosteum is encountered. And then we infiltrate the periosteum and give the injection of the lignocaine there. Now, this can also help in assessing the thickness and depth of the periosteum for later when we are doing the bone marrow examination. So here is how we are taking this 10 ml or 20 ml syringe. It is usually a 10 ml syringe that we take, and we are giving the lignocaine inside, and once we have gone inside, we are touching the periosteum and giving the LA there also in the periosteum. Now 2 to 5 ml of lignocaine is used to anesthetize a roughly circular area of the periosteum, approximately 1 centimeter in diameter. Now there might be certain obese patients in which these needles might not be reaching up to the periosteum. So in these patients, a spinal needle may be substituted. And an emergency crash cart will always be available for doing the procedure. Now we come to the main technique, the bone marrow biopsy technique. Usually this is preceded by a bone marrow aspirate. So once the local anesthesia is done, we wait for a few minutes, preferably 4 to 5 minutes. But in a very heavy load situations, maybe there could be some time that you could not wait for these minutes. But what you do is after you give the local anesthesia, you can maybe do some procedures such as take the peripheral blood of the patient, which is absolutely required for doing a bone marrow examination. So you take the peripheral blood, and that maybe takes up 1 minute, and then you wait for a couple of more minutes, and then you go ahead with the bone marrow aspirate. After the bone marrow aspirate is done, then you do the bone marrow biopsy. Now the biopsy should be obtained to the same skin incision site as the aspirate. The needle should be angled differently to sample a different area and to avoid procedural hemorrhage. So we enter through the same skin incision, but we angle the needle differently so that we don't go to the same area where we had gone to take the bone marrow aspirate. Now the needle is inserted through the skin puncture site, and it is advanced with steady pressure to the periosteum and now twisted onto the surface of the bony cortex. Now once we twist it inside and goes into the bony cortex, we remove the obturator that we talked about. We remove the obturator from the needle, but we do that only once the needle is fixed in the bone. Now when the needle is fixed in the bone and we have removed the stylet, then we further advance the needle for 1 to 2 centimeter with a continuous to and fro, back and forth rotatory movement while applying steady pressure. So here we can see the person who is conducting the bone marrow examination has inserted the bone marrow needle into the bone, and once this has fixed in the bone marrow after that a rotatory to and fro motion has been done to push the bone marrow needle further 2 centimeters at least inside. Now, when it is gone 2 centimeter inside, the biopsy core is broken off from the surrounding bone by vigorously rotating the needle at 360 degrees several times while applying pressure. The needle is carefully withdrawn with rotation through the bone, periosteum, and skin. And finally, when the needle is withdrawn, the stylet is used to remove the biopsy core. But importantly, you must remember that the biopsy core is removed from the distal end of the needle, while the needle is being held vertically with the beveled end up and the hub approximately 2 centimeter above the clean glass microscope slide or piece of sterile gauze. Let me show this to you clearly so we can understand. So this is where we insert the stylet. So we insert the stylet so that the bone marrow that was there is pushed through the needle, the hollow needle, and it comes out through this end, which is the mouth of the bone marrow biopsy needle, and it is pushed onto, here we are pushing it onto a clean tissue paper. Now you can see here it has been pushed and the bone marrow biopsy has been expunged from this hollow needle. Right, so after this is done, the biopsy touch imprints are prepared. The core is placed on a clean side and it is blotted with a sterile gauze. Now this blotting is very necessary because we want to remove the extra blood that is there on the bone marrow biopsy, because otherwise all that will get on the touch imprints will be blood. So we don't want that. We want to we want to remove the extra blood. We blot it with a sterile gauze or with a blotting paper, and then we place it on a clean slide, and a second slide is pressed very gently against the core and rolled slightly from side to side. So 2 to 4 slides with several imprints should be prepared, and the core should be after that immersed in formalin container. The core is put on one slide. It has been completely blotted off, so we can see that there is not too much blood here. And with the other slide, we are rolling it on over the first slide that is kept there. And when all of it is done, when all the procedure is finally done, we should have the peripheral blood smears prepared. We should have the bone marrow aspirate smears prepared. We should have the bone marrow imprint smears. You can see the bone marrow imprint smears, and you can't really see any blood here because the bone marrow biopsy was nicely blotted off before making these imprint smears. And then you place the bone marrow biopsy inside this bottle container, which already has the formalin inside it, or any other fixative that you're using for the procedure. And we have also taken the extra samples for ancillary tests such as flow cytometry and cytogenetics. Now, this is often a question that is asked: is unilateral biopsy enough, or should we take biopsies from both sides? So, should unilateral or bilateral procedure be done? So, for this, what is usually followed is that those disorders which have a patchy infiltration of the bone marrow or patchy involvement of the bone marrow, for them it is usually preferred to do a bilateral bone marrow because we get more area to look for the disease. And on the other hand, those disorders which involve the whole bone marrow completely, which are basically disorders primarily of the bone marrow, for them a unilateral bone marrow will do, because anywhere that you access the bone marrow, you can get the disease. So, in our setting, what we follow is that for acute leukemias, myeloproliferative neoplasms, MDSs, ITPs, and any marrows which we are doing to assess the disease status, for example, for acute leukemia follow-up marrows or any lymphoma follow-up marrows, CLPT follow-up marrows, we are usually doing a unilateral bone marrow examination. However, for lymphomas or plasma cell dyscrasias, aplastic anemias, any suspected METs, any pyroxia of unknown origin, including HLH, any storage disorders, any Langerhans cell histiocytosis, in all these cases, the infiltration might be patchy and might not involve the entire bone marrow together. So it is better to do a bilateral in such cases. Now, after this is done, we should not forget that the post-procedure care is also very important. And here the bleeding must be stopped by applying pressure with gauze on puncture site for approximately 1 minute or till the bleeding stops, and then clean up the procedure site with isopropyl alcohol soaked swabs, and then bandage is placed. So here is how we put pressure on the site. So we apply pressure here so that the bleeding stops. Sometimes in thrombocytopenic patients, the bleeding might go on for a couple of minutes or even more. You have to ensure that you just keep applying enough pressure there so that the bleeding finally stops. And after the bleeding stops, you put the cotton pads there. Maybe you can put some tincture iodine, and then cleanly with a band-aid, you seal the place off. Now, are there any complications of this bone marrow biopsy procedure? Well, bone marrow biopsy is a relatively safe procedure with very low risk of morbidity. Mortality is almost extremely rare with aspiration and biopsy from the iliac crest. That's why we have said that sternal biopsy should be avoided at all costs. It should be done mainly from the iliac crest. And post-procedure persistent pain is one of the most commonest complaint of the bone marrow biopsy procedure. And if we apply a good local anesthesia before doing the procedure, the pain is actually minimal, and sometimes the patient feels no pain at all. Hemorrhage is a very rare complication at any site. However, you know that patients with who have bone disorders and also who have thrombocytopenia can have bleeding complications, especially patients who have a bleeding disorder. It's really risky to do bone marrow procedures in patients who have bleeding disorders. Now, breakage of needle or separation of the handle can also occur very rarely, and this would require orthopedic consultation. In my practice and what I've heard from a department in the last 5-10 years, maybe only 1 or 2 such cases has happened, and the patient has had to be rushed to the orthopedic OT for removal of the needle that has got stuck inside. But this is very rare now with good quality needles that is available, especially the Jamshedi line of needles that is available with us now. So with that, we go on to the bone marrow processing, now that the procedure is over. So how do we process the bone marrow biopsy sample? So now coming to fixation, various methods for fixation are available, and however, neutral buffered formalin is by far the most commonly used. We also have zinc formaldehyde, B5, AZF, IBF, Boone's fixative, and formaldehyde and glutaraldehyde. And time for fixation varies from 1 hour to more than 24 hours depending on the fixative that is used. However, the most commonly used is the neutral buffered formalin for around 10 to 24 hours. Now, why is there this difficulty in bone marrow processing? That is because the bone marrow tissue that we take out, the biopsy, the trephine biopsy that we take out, has a hard structure that is a bone, and also the soft structure that is a bone marrow. So, how do we do the bone marrow processing? There are 2 ways of doing it. One is to make the hard structure that is a bone soft by decalcification of the bone to make it soft like the bone marrow. The other technique is that we embed the bone marrow in a substance, for example, a hard substance like plastic, which makes the bone marrow as hard as the bone. So both of these can be done. However, the plastic embedding is not very commonly done, especially in India. What are the advantages and disadvantages of these? Well, paraffin embedding has considerable shrinkage and loss of cellular detail. So that is one disadvantage of this. However, some cytochemical activity may be lost in paraffin embedding as well, but we rarely do cytochemical activity, cytochemical stains on the bone marrow biopsy. However, it is very good for IHC though. And of course, it is very widely used, and technicians are much more comfortable with this, and it is also much cheaper. What about plastic embedding? It really does not cause any shrinkage, and the cellular details are much better preserved in the plastic embedding. And also the enzyme activity is retained. However, it is much more expensive. It is technically also much more challenging, and there is a lot of background staining when we are doing IHC. So most centers, you'll find that paraffin embedding is what is being preferred there. And when we are doing paraffin embedding, the next step becomes decalcification, and various methods of decalcification, that is making the bone soft, is used. And we have EDTA, formic acid, acetic acid, picric acid, nitric acid, and some commercial decalcifying agents. EDTA is basically a chelator, formic acid and acetic acid are weak organic acids, picric acid is an explosive that is not commonly used anymore, and nitric acid is a strong acid. Well, neutral buffered formalin with EDTA decalcification gives adequate morphology, preserves antigens for IHC and nucleic acids for molecular studies. So this is all very commonly used decalcifying agent. After decalcification, the biopsy specimen is embedded in paraffin wax and section is cut on a microtome. The recommended thickness of the sections is around 2 to 3 microtomes only, not thicker than that. And at least 6 sections should be ideally cut, but in most places you get 2 to 3 sections on a single slide. Staining is by H&E section, by staining. GIMSA staining is also done in some places. And additionally, reticulin staining in all cases in which marrow fibrosis is suspected should be done. Also, in any cases where there is diluted bone marrow aspirate, when there is dilution of the bone marrow aspirate, the cause could be bone marrow fibrosis. You can already, while looking at the bone marrow aspirate, you can order for a bone marrow reticulin stain. And additional sections should also be cut if immunohistochemistry or histochemical stains are required. What do we do in our lab? We fix with a 10% neutral buffer formalin, which is overnight fixation. That is 15 hours to 20 hours is how much the duration of our fixation. And the decalcification that we use is the 8.5% nitric acid. The nitric acid is a strong acid that we are using for our decalcification. An advantage of this is that there is very quick decalcification, and we use the decalcification only for 5 hours and 15 minutes. After the decalcification is done, the biopsy is wrapped in tissue paper along with the label and transferred out to the tissue processor. And because we are using nitric acid, biopsy sections are submitted to the reporting just 2 days after the procedure is performed. EDTA, as we spoke about EDTA is a good agent for doing decalcification and also provides good morphology. However, it takes much longer time than this, and in a high turnover lab which has numerous procedures happening every day, nitric acid is a very good alternative, and we don't really have any problem with the morphology here. Okay, now that the processing is over, we come to the bone marrow biopsy evaluation. Right, so we must remember that bone marrow biopsy and bone marrow aspirate are complementary procedures. Examination of the bone marrow aspirate in isolation will not be helpful because cytomorphological features will be very well identified, but we cannot give the full interpretation by bone marrow aspirate alone. What about bone marrow biopsy in isolation? Again, there can be proper evaluation of the histomorphological abnormalities, but it will not again be a full evaluation of the case. And without clinical or hematological features and aspirate findings, there always will be a risk of over-interpreting the bone marrow biopsy or failure to provide adequate interpretation of a bone marrow biopsy. Now, we must remember that trephine biopsy is just a definite diagnosis on a bone marrow biopsy, and therefore, for reporting trephine biopsies, it should be what is suggested is that it should be done by a hematopathologist who can interpret both the bone marrow aspirate as well as the bone marrow biopsy, or if that is not possible, then the histopathologist and the hematologist should sit together and interpret the findings in totality. Now, bone marrow biopsy interpretation is actually one of the most difficult areas of histopathology. The organized structure of hematopoietic tissue is not actually as readily apparent as that of many other tissues, and a systematic approach is required, for which we should have a working knowledge of the normal microanatomy and the pathological changes that may occur, and a methodical examination of the various component parts of the bone marrow should be done. So we need to have a good knowledge of the bone marrow anatomy. So with that, we go ahead and see how we approach a bone marrow aspirate. So what are the components of the bone marrow aspirate? Here we have bone, stroma, vessels, reticulum and fibroblast, and adipose tissue. These are components of bone marrow which are sometimes forgotten. When you ask a postgraduate student what are the components of bone marrow, he'll talk about the hematopoietic elements but forget about these, but these are very, very important components of the bone marrow. And after that, we also have the hematopoietic tissue, which contains the granulocytic series, the erythroid series, the megakaryocytic series, the lymphocytes, plasma cells, mast cells, and macrophages. This is a view of the bone marrow biopsy specimen. So we have the periosteum, then we have the cortical bone, and we have the subcortical areas, which are usually very hypocellular and should not be used for assessing the cellularity. And then the cortical bone from near the periosteal region, and as we go down and deep, the bone becomes trabecular bone, and we have the bonicular trabeculae, and between the intertrabecular spaces, we have the hematopoietic tissue along with the fat. Right. So we talked about these hematopoietic tissue and the hematopoietic cells. We must remember that the hematopoietic cells are not arranged at random, but they have a consistent spatial relationship to the other components in normal samples. So early myeloid precursors are found adjacent to the endosteal surface, and as they mature, the mature myeloid cells, the erythroid cells and megakaryocytes are found in the central intratrabecular region in association with the marrow sinusoids. So these myeloid precursors, they mature from the bony trabeculae, adjacent to the bony trabeculae. They mature inwards into the interstitium, and they come in association with the bone marrow, the sinusoids, and from there they enter the sinusoids and come into the circulation and form the elements of the peripheral blood. However, we know that this arrangement can be easily disrupted by pathological states, and that is what we are doing when we are doing a bone marrow examination. Now, is there any adequacy criteria? Well, WHO defines an adequacy criteria and says that the bone marrow biopsy should be 1.5 centimeter in length and should have at least 10 intratabular spaces to be examined to give a proper interpretation. However, is that necessary? Well, if you have a length of less than 1.5 centimeters and you have lesser number of intratabular spaces, that will suffice as long as the disease pathology can be identified. So this is good to have more than 1.5 centimeter length biopsy and 10 intratabular spaces. However, any length will suffice as long as the disease pathology can be identified in the bone marrow biopsy sample. Now we come to the systematic approach to a bone marrow biopsy section. So, like for bone marrow aspirates, even for bone marrow biopsies, initially a low power examination is what should be done, and it should be preferably done at a 4x magnification. What are the components that we look at when we are looking at a bone marrow low power? We are assessing the cellularity. We are looking at the megakaryocyte number and distribution. We are looking at bone abnormalities, which we can't really assess with the bone marrow aspirate. We are also looking for focal lesions like granulomas and infiltrates such as metastases and lymphomas. And of course, we are also looking for the adequacy. What is the size? What is the composition? Do we only have bones or cartilage, or do we have the hematopoietic elements as well? Is there marked crushing or something like that? So is it adequate for opinion? So now we come to cellularity. Cellularity was something that we discussed in great detail in our last class. So let me just say that measurement of cellularity is basically the measurement of the ratio of hematopoietic cells to fat. And at birth, the marrow space is nearly entirely filled with active hematopoietic tissue, but with aging, it gradually decreases in cellularity. Now, this is a graph that we see of the bone marrow cellularity that is decreasing with age, and you can see there is gradual decrease in the early years of life, but from the 30 to 70 years, there is almost a plateau where the cellularity does not really decrease, and then after 70 years of age, there is again a sudden steep decrease in cellularity of the bone marrow. Now, normal cellularity, you can use a formula of 100 minus age. For example, if the age is 40 years, the patient should have around 60% cellularity, and this is a rough estimate of how the cellularity should be estimated in the bone marrow. But we know that multiple variables affect the bone marrow cellularity, and the most important is the site of the bone marrow examination from where it is done. Now, the cellularity of histological sections can be assessed most accurately by computerized image analysis that will give us nice and detailed cellularity of the bone marrow. Or alternatively, histomorphometry can also be used, where point counting is by an eyepiece with the graticule is used. However, these are techniques that are not used in most places, and subjective evaluation of cellularity is what is done in most places, including ours, and such estimates of cellularity are less reproducible, but they are almost show a reasonable correlation with the histomorphological features. So now, where to assess the bone marrow cellularity? So if we look at this, we can see that this is the periosteum. We have the we saw that there is a subcortical, the cortical area bone, and the subcortical areas. Now, if we assess the cellularity here, almost all bone marrow examinations that we do will have hypocellular bone marrows, because these areas are actually hypocellular always. Now, if we go a little further, you can see that the cellularity is increasing. And now, if we complete the picture, we can see that this is actually, for say a 20-year-old, this is actually a hypercellular bone marrow or a normal cellular bone marrow for a 10-year-old. So this is the area where you should do the bone marrow cellularity assessment, and not in the subcortical region. So this is something that has to be avoided, and we know that the bone marrow cellularity has to be assessed after moving away from the hypocellular subcortical region. Now, normal middle-aged individual will have approximately 50% cells and 50% fat. So there will be around 25 to 75% cellularity, and normal in individuals with 20 to 70 years of age. Now, except in extremely old age, cellularity of less than 20% indicates hypoplasia, and except in those who are less than 20 years of age, cellularity of more than 80% is likely to indicate hyperplasia. This is the rule of thumb that we can use while assessing cellularity, and we know that the bone marrow biopsy is the gold standard for assessing cellularity. Now let us come to some cases. We have a 31-year-old female who would come for pancytopenia after evaluation. Now, if we look at the biopsy here, we can see that the cellularity is nearly, say, around 40%, 50%, or maybe around 50%. So we don't really know what the cause of the pancytopenia that the patient is having. But if we move slightly away from this region, we can see that there are also other regions which are almost completely hypercellular. And if we move further away, we see that there are a number of intratrabecular areas which are completely hypocellular. So this is a very good learning point, that you should have an adequate length of biopsy so that we don't get just these areas, but we also get the representative areas which will tell us that this patient is probably an evolving aplastic anemia. And if we start treating the patient for aplastic anemia, he'll probably respond and his pancytopenia will improve. And now this bone marrow is hypercellular bone marrow for any adult individual. You can see that the marrow spaces, there are no fat at all. It is only the hematopoietic elements that is covering all the marrow spaces. But one must remember that hypercellular bone marrow does not necessarily mean a myeloproliferation. It can even be there in any reactive condition. So, for example, if there is a strong infection in the body somewhere, as a reaction to that, also the bone marrow can start producing a lot of cells and can become hypercellular. If there is anemia, then also in response to that, there is hypercellularity. So, hypercellularity does not really mean only myeloproliferation and MPNs. Now we come to the megakaryocytes. Now, megakaryocyte assessment, what do we do here? We study large cells. So, megakaryocytes are basically very large cells, around 30 to 160 microns in diameter, and they are visible in scanning and low power. And there is a marked degree of heterogeneity in both nuclear DNA content and nuclear size. Why is this happening? Because of endoreduplication. This is something that we learned in the last class. There is a special site of cell division when, and sometimes go as far as 40N, 64N to even 128N, and the 16N megs are the most commonly found ones that are found in the bone marrow. Now, for bone marrow megakaryocyte assessment, it is necessary to assess megakaryocyte numbers as well as morphology, and a subjective assessment that is done usually, and we say that megakaryocytes are either decreased or increased or normal for the age. Somewhat fewer, what is important to know is that somewhat fewer megakaryocytes are seen in sections of aspirated fragments than in the trephine biopsies, possibly because these large cells are not as readily aspirated as the smaller marrow cells. Now, this is a table from WHO which explains to us why megakaryocyte morphology is so important in the myeloproliferative neoplasms. We can see that megakaryocytes is increased greatly in all of them, but it's really increased in ET or essential thrombocythemia. And we see that giant megakaryocytes are also found in most cases, but again, ET has more of giant megakaryocytes than others. What about the histography and the cluster formation? We see that dense clusters and loose clusters are mostly found in PMF, although they are found in other cases as well. They are found in ET and PV as well. But dense clusters especially are mostly found in primary myelofibrosis. And what about the nuclear features? Hypernovation is usually a sign of either ET or a PV, and maturation defects are usually seen in the primary myelofibrosis. Now we go on to dysmegakaryosis. We have learned these features of dysmegakaryosis in the last class. We move ahead and we know that dysmegakaryosis and megakaryocyte morphology is also features of myelodysplastic syndromes, the MDS MPNs. Now we come to this case of a 52-year-old male who had splenomegaly. His hemoglobin was 14.5 gram per deciliter. The TLC was around 18,000 and the platelets were around 5.2 lakhs. The MCV is 62 femtoliter and the MCH is 21 picograms, and we have microcytic hypochromic blood cells in the peripheral blood. Now what we see here is that the bone marrow is markedly hypercellular for a 50-year-old, in fact for any age, because it is nearly 100% cellularity here. But what we can also see is that there are a lot of megakaryocytes in this bone marrow. If we take a closer look, you can see that this intertrabecular region has numerous megakaryocytes, and cluster of these megakaryocytes is being formed. But these are loose clusters, and we also know that we can also see that in the paratrabecular region, these megakaryocytes are also seen here. We learned that the megakaryocyte should be inside in the interstitium and not in the paratrabecular region. But we can see that there is distortion of topography here, and the megakaryocytes have moved to the paratrabecular region. Other than that, we can also see that there is a lot of dissimilarity in the morphology of the megakaryocytes. We have some very large and hyperlobated megakaryocytes. We have some very small megakaryocytes and normal sized megakaryocytes as well. So what is this now? This is definitely a myeloproliferative neoplasm. It cannot be ET because the hypercellularity is there. The essential thrombocythemia bone marrows are usually normocellular and they're not really hypercellular. So is this polycythemia vera? But we saw that the hemoglobin was only 14.5 gram per deciliter. So it does not really fit with the main morphological WHO criteria of polycythemia vera. What can it be? We know that in India, iron deficiency is really, really common. So this patient could actually be a polycythemia vera with iron deficiency, or the second differential diagnosis here would be a pre-fibrotic PMF also. Now we can resolve this differential diagnosis by giving this patient iron, seeing if his hemoglobin increases and goes beyond 16.5 or not. If it does, we know that the patient is actually a polycythemia vera who has iron deficiency. However, if it is not iron deficiency that is causing the microcytosis, it is probably a case of pre-fibrotic PMF. Now here we have a 45-year-old female who has macrocytic anemia and thrombocytosis. Here also we can see there is largely increased number of megakaryocytes. Numerous megakaryocytes can be seen. And from here, from this view only, from the scanner, we can see that some of these megakaryocytes, in fact most of these megakaryocytes are hypolobated and round. And we take a closer look and we see these megakaryocytes showing smaller in appearance, and they have hypolobated round nuclei. So this is very classical of MDS with deletion 5q, and that is what we found on FISH testing in this patient. Now, other than the bone marrow, cellularity and megakaryocytes, the low power also shows us about infiltration. So here we have a 48-year-old lady with generalized lymphadenopathy, and on scanning power we can see that there is this lymphoid nodules. So the lymphoid nodules can be either benign or malignant, but here we can see that the lymphoid nodule, the borders of these lymphoid nodules are not really well defined. They are disseminating into the surrounding structures, and this is probably a malignant lymphoid nodule. And when we take another look, we see that there is this trabeculae, and the lymphoid cells are all lined along the trabeculae. If we take a closer look, we can see that there is a junction of these three trabeculae, and the lymphoid cells are sleeving these trabeculae and forming these clusters around the trabeculae. So this was actually a follicular lymphoma with a paratrabecular infiltration, which is a very common pattern of infiltration seen in follicular lymphomas. Now we have I'll give a case of a 47-year-old male who had fever and cough. He was suspected to have pancytopenia, and he was being worked up for pancytopenia under evaluation. He had splenomegaly as well, and he turned out to be positive for SARS-CoV-2, that is COVID infection. Now with the bone marrow examination, bone marrow aspirate revealed these nice hemophagocytosis. So fever, pancytopenia, splenomegaly, hemophagocytosis. We thought that the patient had a secondary HLH, and that is the diagnosis that we made in this case, who was COVID positive, who had been COVID positive. But when we did the bone marrow biopsy, we saw that there were these granuloma formation. When we take a closer look, we can see that these are necrotizing granulomas, and we can also see a lot of epithelioid cells. And when we probed, we saw that the patient had a past history of tuberculosis, and probably this was reactivated because of the COVID infection. So here also the bone marrow biopsy helped us clinch a more diagnosis. The patient was given, after being treated for COVID, was given ATT as well, and the patient is now doing well. This is an AFB that can be seen sometimes in the bone marrow biopsy. So frankly, when we are using nitric acid as a decalcifying agents, we don't really get to see a lot of AFBs, even in patients who are positive for tuberculosis. Even in those granulomas, we don't really get to see too much of AFBs. But this was a patient who was actually HIV positive. And in HIV positive patients is the only cases where I have seen these acid bacilli in bone marrow biopsy sections. Now we come to another case. This is a 62-year-old male who was being evaluated for anemia and thrombocytopenia. When we saw the peripheral blood, we could see that there were numerous schistocytes here. So we thought that there was possibly some thrombotic microangiopathy, maybe a TTP or an HUS. But when we did the bone marrow biopsy, we saw that the bone marrow biopsy had a lot of fibrosis and some strange-looking cells were seen. We took a closer view, and again we saw that few just focal areas where these strange-looking cells were present. They did not look like any bone marrow cells, normal bone marrow cells, and so we went ahead and did immunohistochemistry on this biopsy, and this turned out to be positive for cytokeratin. So we informed this to the clinician. We did an imaging, and a small lung mass was noted, and the biopsy of that small lung mass revealed it to be a CL lung. So there was basically a thrombotic microangiopathy that was present in a CL lung, which was metastasizing to the bone marrow. Now we come to a 21-year-old male who was a CKD stage 4, and again he was being worked up for anemia under evaluation. It is very unusual for a 21-year-old male to have CKD. This patient also had a history of recurrent nephrolithiasis since childhood, and when we looked at the bone marrow biopsy, we could see these strange-looking crystals. And when we came closer, yes, we can see these crystals almost being arranged in flower-shaped pattern, and this is the so this is basically oxalosis, which was there in this patient. This could be primary or secondary oxalosis. For that, we need to do a genetic screening, and we could not really do that because the patient was not affording for that, and the patient was lost to follow-up. But again, beautiful flowers of oxalosis can sometimes be seen on microscopy, and plain and polarized light will really show these crystals to come out very beautifully. After that, we also have some bone diseases which we can see from the low power viewing. So here we can see a 55-year-old male with anemia under evaluation. He also had CKD, and we can see that the bone intrabacally are irregularly thinned out at places. And we take a closer look, we can see there is osteoclast activity that is causing this tunneling of this bone, and this is CKD-related changes of the bone in this patient. Another patient was a 48-year-old male, was CKD stage 5, was also being evaluated for pancytopenia. You can see this very nice paratrabecular fibrosis in this patient, and also you can see if this bone intrabacally there is a closer look. You can see that the bone marrow elements are trying to get inside. Again, osteoclastic activity happening. This bone is lined by osteoblasts as well. So again, parathyroid, hyperparathyroidism related changes in this patient of CKD. Now we come to this strange looking bone marrow, which is a 17-year-old male who had pancytopenia, and there was 15% blasts in the peripheral blood. He also had history of deafness, and there was similar family history present. And we can see that there is this very strange looking irregular bones which are thickened and irregular, and these are basically woven bones which also have cartilaginous islands and areas of calcification. These are basically impinging upon the bone marrow hematopoietic elements, and almost no hematopoietic elements is left at all. So this is something that we find in osteopetrosis. That was the diagnosis in this case, and the patient had a family history of osteopetrosis. Very important to note here that the bone becomes really hard in osteopetrosis. So even while doing the procedure, the bone marrow, the person who is doing the procedure can feel that the bone marrow needle is not even entering the bone, and so that can be one clue at the outset that this patient could actually have osteopetrosis. So in a couple of cases of osteopetrosis that we have seen here, we have experienced this, that the bone, it is really difficult to get inside the bone because the bone becomes so hard. So now that we have seen that on the low power, we can assess the cellularity, we can assess megakaryocytes, we can assess for infiltration by METs or other things like oxalate crystals as well, and we can also look for bone diseases. Now after the low power examination, what do we do? So after low power examination, the hematopoietic elements and the marrow stromal elements should be studied using the medium power, that is 10x and 20x, and also the high power. In oil immersion in bone marrow biopsies is usually not required. However, they can be very helpful to assess the fine cytological details, for example, a normal lymphoid cell population or the metastatic tumor cells. With a little experience, the person who is examining the bone marrow can have visual estimations of the malocellularity, of the relative amounts of the granulocytic and erythroid elements, and if there is any deviation from any normal, that can be easily made with some experience. Now, Erythroid series, in the Erythroid series, what we have to look for is the presence and appearance of erythroblastic islands. We have to look for the morphology and degree of maturation of erythroblasts, and we have to look for evidence of dyserythropoiesis, which of course is much better visualized in the bone marrow aspirate smears. So here we have a 15-year-old male with autoimmune hemolytic anemia, and the bone marrow examination was done here to rule out any lymphomas that could be causing this autoimmune hemolytic anemia. And what we saw here are these nice erythroid islands and erythroid hyperplasia, which we can appreciate in the high power. This normoblastic erythroid hyperplasia. There's another patient who had pancytopenia evaluation. The hemoglobin was around 3. There's not a very good quality picture, but you can see that there are a lot of immature looking cells. If we come closer, yes, we can see that there are a lot of these cells which are absolutely opened up chromatin, and their nucleus looks very immature. But you can also see that there are, or most of these cells also have this reddish nucleoli, and these are elongated nucleoli, and some of these nucleoli are sticking to the margin of the nucleus, sticking to the nuclear margin. So this is a characteristic appearance of megaloblasts. It is really very difficult, and a lot of people might confuse this with actual blasts and acute leukemias. So it is dangerous to view this specimen of bone marrow biopsy without the bone marrow aspirate. So when we look at the bone marrow aspirate, this is the megaloblasts that we see on the bone marrow aspirate, and there is a very nice correlation. So this was a case of megaloblastic anemia. Now this is the 30-year-old male with anemia under evaluation, and if we look at closely, we can see that there is really no hypocellularity or hypercellularity, but we also see that most of the elements here are the granulocytes, and very little erythroid series cells are present. We can see some erythroid series cells which are large and probably megaloblastic. They are probably the proerythroblasts, and this patient had pure red cell aplasia. Coming to the granulocytic series, the morphology and relative proportion of immature and mature granulocytic precursors is what should be noted, and the position of the immature precursors is also a very important thing to be noted. So here we have a patient, we have a bone marrow biopsy where you can see numerous immature cells which should have been present in the paratrabecular region, but these numerous immature cells are coming and they are almost replacing the normal hematopoietic elements. Here also you can see that these are the immature cells that are coming into the interstitium. So this is how an AML will look. This is a case of a 28-year-old male who has pancytopenia, and the bone marrow was done for a pancytopenia in a 28-year-old male. And this area, if you look at this area, we'll see that we'll think that there's probably some hypocellularity going on, and there's probably an aplastic anemia. But if we do an IHC for CD34, we can see that there are these CD34 positive cells, a lot of these CD34 positive cells that, as we mentioned, the CD34 positive cells are basically the immature myeloid cells. These immature myeloid cells should be present in the paratrabecular region and not in the interstitium. So the presence of these CD34 positive immature myeloid precursors in the interstitium says that something is wrong. There is a distortion of the topography of these myeloid precursors from the paratrabecular area. They have come to the interstitium. This feature is called as atypical localization of immature precursor, or AIIMS, and this is what is found in MDS, and this patient was actually diagnosed to be hypoplastic MDS. Megakaryocytes, we have already seen that even on close view, we should assess the morphological features, localization, presence and absence of clusters, etc. And special attention should be paid to the cell size and nuclear morphology. Now the lymphoid series, again the numbers, localizations, morphology of lymphocytes and plasma cells should be noted, and the presence and position of morphology of the lymphoid cell aggregates or plasma cells aggregates should also be noted. Here we can see an IHC of CD138 that is very specific for, quite specific for plasma cells. So, and here we can see a case which had around 6 to 8% plasma cells on the bone marrow aspirate, but we can see that there are some areas which are showing increased plasma cell by CD138. If you take a closer look, we can see that this is actually a vessel, and that these areas where there is increased plasma cell is actually in the perivascular location. That is the normal location of the plasma cells. Plasma cells in the bone marrow are accumulated around the vessels, and they form this kind of cluster. So this is not abnormal, but this is normal. However, some different areas in this bone marrow also showed aggregates of the bone marrow of the plasma cells. So there were actually aggregates of plasma cells as well, and these normal localization of plasma cell as well. So this was basically a patient who had 6% plasma cells. On flow cytometry, these plasma cells came out to be clonal, and the patient was actually MGUS, but then we found out that the patient also has amyloid. So it was basically a case of amyloidosis, which had around 6% plasma cells and focal aggregation of these plasma cells. We should also look for macrophages with the number, evidence of hemophagocytosis, phagocytosis of microorganisms, and lysosomal storage disease such as Gaucher's disease. And now coming to the most important, not the most important, but a very important element, which is often missed and neglected and not examined properly, which is the stromal elements. Important changes to be noted in the stromal elements are gelatinous change, fibrosis, edema, amyloidosis, and vasculitis. So again, we come to a case. This is a known case of polycythemia vera who was diagnosed 10 years back. Now the erythrocytosis has reduced and the patient now has anemia. We can see that the bone marrow is really hypercellular, which is expected in polycythemia vera. But we can also see on a closer view that a lot of these cells are forming straight lines. They are streaming along in the interstitium. And when we did a reticulin stain, we can see that there is really high concentration of reticulin in this bone marrow biopsy. And this is actually a case of polycythemia vera that is now converted into myelofibrosis. This is the grading of myelofibrosis that is used by WHO. There are various grading systems. Whatever you use can be used, whatever you wish to use. However, when you're giving the report, you must mention which grading system you are using in the report. Now we come to another case. This is a 46-year-old female who was a known case of chronic kidney disease and was pancytopenia under evaluation. The bone marrow was performed to look if there are any hyperparathyroid-related changes in the bone marrow, but we saw that there was hypocellularity. But also, it looked very strange. We don't really find the normal hematopoietic elements or the normal fats also. Does not really look like fat. And when we come take a closer look, we can see that there are these granular elements here. This is not really looking like fat. Here again, we take a much closer look and we can see that there are these granular elements in the bone marrow. The normal cells are not there. The normal fat is also not there. So when we took some history, this patient was, while the person was conducting the bone marrow said that the patient was actually markedly cachexic, and this is what is called as the gelatinous transformation or the serous degeneration of the bone marrow. So in markedly cachexic patients, in patients having chronic long-standing diseases like chronic kidney disease, we get this. In today's age, we also get this in very commonly in HIV patients and patients who also have anorexia nervosa. This was the bone marrow aspirate of the same patient, and we can see that this gelatinous transformation, this is how this looks on the bone marrow aspirate smears. You can see this pinkish gelatinous material around the bone marrow aspirate particle. Biopsy examination, we finally come to how a bone marrow biopsy report should be. This is an article by Lee et al., which gives the ICSH criteria for bone marrow examination, and these are the various elements that should be present in a bone marrow report. We should have the name of the institution, the unique specimen identifier, details of the patient, names of the responsible physician, names of the requesting doctor, etc. And of course, we should have the aggregate length of the biopsy, adequacy and microscopic appearance of core, percentage and pattern of cellularity, and bone architecture. We should also write the location, number, morphology, and pattern of differentiation of erythroid, myeloid, megakaryocytic lineage elements, the lymphoid cells, plasma cells, and macrophages, abnormal cells, reticulin stain, IHC, histochemistry, other investigations like FISH and PCR, and we should give a conclusion and sign out the report. I'll finish by showing a report from our department of this patient who had, we give the names and the details of this patient. We look at the bone marrow findings, we'll look at the bone marrow aspirate findings, and then we look at the trephine biopsy report. We give any cytochemistry is there, and we finally give the trephine biopsy report. In the trephine biopsy report, we'll write about the measurement of the trephine biopsies. We write about the cellularity of the biopsy. We have seen that there are epithelioid cell granuloma formation, so that is what we'll mention here. We'll also mention that large atypical monocellular cells, anything that is abnormal should be mentioned. And then we should mention about the normal hematopoietic elements, if they are present, if they are proportionately present, if they are increased or decreased, and if there is any IHC that should be done, that should also be mentioned here. It was a known case of Hodgkin lymphoma, and it was positive, so that was the final interpretation. We gave the reticulin stain as well, and this was the final interpretation that was given in this bone marrow as a known case of Hodgkin lymphoma, bone marrow shows infiltration. With that, I thank you for your patient listening, and this is my team that I'm working with at PGI Chandigarh. I'm very lucky to be a part of this team, and I now thank you for your patient listening, and I'm open to any questions that you have on this topic. Thank you.
Thank you, Dr. NABHAJIT. Wonderful. Have a glass of water. You must be really tired.
Yeah, thank you so much.
Wonderful presentation. Absolutely complete. Nothing was left. You have, you have done real justice to the topic. Every bit of it, what is required for trephine biopsy, right from the procedure to the various methodologies, to the various elements, cellularity, and how to report, and finally how the report looks like. let us wait and see if there are any questions on the YouTube.
Thank you, sir. But I just want to say that you said that this is complete, but this can't really be complete because bone marrow examination is such a wide thing and we have so many different elements to it. I just tried to give an overview of how we should approach it.
Yeah, if you understand, this is under the chapter of fundamental aspects of hematology.
Right.
As we go into the specifics, each and every speaker who's speaking on the specifics will be
Absolutely.
addressing that part, the flow cytometric part, the cytomorphology part, as
Right.
well as the Trephine Biopsy part. But
Absolutely.
more important, this is one thing which is most neglected.
Yes,
Most
sir.
of the people just rush in to see how a leukemia looks like without understanding exactly how to do it to see the
Yes.
leukemia. So
Absolutely.
that is very difficult to teach, and I think everybody can teach leukemias, but everybody cannot teach how to do a bone marrow and a trephine.
Right.
So let me see if there are any questions on the YouTube. In the meantime, I will request you, once you are through with it, just please share the PDF of
Yeah,
this
absolutely.
lecture. We will share it with the students on the Google Drive.
Sure, sir. Absolutely. I'll do that. And you can share my email ID with the students if they have any
Yes, I
questions.
will share your email ID on the Telegram group.
Right.
So if
Absolutely.
anybody
But
wants
yeah,
to write to you, they can write to you directly. Thank you
absolutely.
for that,
Yeah.
offer. Right. So there are no questions on the YouTube as of now. If
Right,
there
sir.
are any, I'll post it to you straight away.
Sure, sir.
Thank you so much. Wonderfully done. Thank you for all the effort which you have taken. It takes a lot of effort to compile a lecture like this and to present it on a weekday, taking out time from your such a busy schedule. I can understand it's very busy in PGI as of now. Thank you so much, Dr. Nabhajit. Would you
Thank
like
you
to
for the
say
kind words,
anything
sir.
at the end? And
Absolutely.
we will close.
Thanks, doctor.
Thank you. God bless you. Take care. Bye bye. Thank you so much. Good night. Bye.